Hello, Web Shadowers. Thank you all for attending our session this afternoon.
Today, we are honored to re-host Dr. Ellis, who will be teaching us about dermatology.
And as always, please remember that the Google form will be posted in the chat box and in the description of this video in the end.
So with that being said, Dr. Ellis, you may begin whenever you're ready.
Okay, great. Hi, everyone. Like they said, my name is Dr. Samantha Ellis. I am a board certified dermatologist. And so this is my second time being on Web Shadowers, so I'm really grateful to be rehosted here. Hopefully, if you haven't seen my last session, it's a little bit more of the fundamentals of dermatology, which I'll talk about later. But moving into today, I think we'll get kind of into some more meaty cases. So without further ado, oh, maybe not. There we go. So this is something I talked about in my first session, but I kind of wanted to go over it just really briefly in case you hadn't seen that, to just reintroduce myself. So I did my undergraduate education at UCLA, 4 years, and I did not take any time off between undergrad and medical school. And people, I feel like, always ask me, like, should I take time off? Do I need to? And really, it totally depends on, like, what's your goal? What's your timeline? Do you need a couple years to kind of figure out if being a doctor is what you really want? Because the journey doesn't, like, it's a long journey. So I really recommend that you be so sure that you want to do it before you go to medical school. And it is totally fine to take a year or 2 or 3 or 5 off before you pursue that. I had lots of people in my medical school class who pursued other careers in finance, in art, in PR, before they came back to medicine. And I feel like those people were so solid in their convictions about wanting to be a doctor because they had taken some time to experience other industries. And I think they really excelled in medical school because they were so passionate, and they realized, like, they had to do another career to realize that medicine was their true calling. And I think there is absolutely nothing wrong with that. And I really admire people who take the time to make that decision. I obviously did not take time in between, and I stand very firmly in being a doctor. I'm so happy that I made that career choice. But it's not wrong to question whether or not you want to be a doctor or take time off in between. And just because you do that, it does not mean that your career in medicine is over. I actually think those people tend to excel even more in the medical field because they have a little bit more life experience and perspective. So I went out to Michigan. So I'm from California. I went to University of Michigan for medical school, which was awesome. I loved it there. And then afterward, I did an intern year in Colorado, and then I did my which is general medicine. So I did surgery, I worked in the ICU, I did emergency medicine. It was sort of like rotating through all of the hospital fields. And then I did my dermatology residency at UC Davis. And a lot of people asked me, so when you're in medical school, you do this thing called the match, where you interview at a bunch of programs, and then you rank where you want to go on a list, like 1 to 10 or 1 to 15, however many places you interviewed at. And that home program, like the programs, rank you as well. And so, like, say I interviewed at UC Davis and I ranked them as number 1, they may have ranked me as number like 4 or 5 or 6. And there's this huge algorithm that matches you up. And so you don't really know where you're going to end up until something called match day, which is what happens in your last year of medical school. And when you're doing something like dermatology, it's required that you do an internal medicine year, like I did my first year, and you match at the same time. So I had to, like, rank programs of where I wanted to match for my first year and rank programs where I wanted to match for my 3 years of dermatology. And you can't coordinate them. So some people, like me, I ended up in like 2 different states. These happened to be my first 2 choices. I wanted to be in Colorado for a year, but some people end up in like Hawaii for their intern year, and then in like South Dakota for their 3 years afterwards. So it's just something to keep in mind, that is a really unpredictable process for people. So if you have a family or you have certain goals about that, it's something to keep in mind. And then now I am in private practice in Danville, California, which is right outside of San Francisco. I go more into detail in my last sort of presentation, but I wanted to give you a little bit of an idea of what I do. When you're a dermatologist, you can be in private practice, meaning that you're seeing clinic patients every day. You can be in academics, meaning that you work for a hospital system like in my area, the people who are in academics are either work at like Stanford or UCSF or UC Davis. Those are like the Northern California academic programs. And so you might do clinic a few days, you might see patients in the hospital once in a while, you have teaching as part of what you do. And so there's many different ways to be a dermatologist, and your practice can look really different. And that's actually something I really like about my field, is that you have your day can look really different depending on where you work and what you want to focus on. And so I like that ability to choose what you're interested in and focus in on that. All right. So from moving into like true dermatology now, from the lecture I did last year, which is last September, which I can't believe it's been that long already. That was more of an intro to dermatology. So that was like, what does dermatology entail, which is skin, hair, and nails, as well as mucous membranes. We talked more about how to collect information. So when you are a doctor and you're meeting a patient for the first time, the biggest part of that initial encounter is information gathering. You're trying to get as much information that is relevant to the patient's complaint that they're coming in with, to really understand that patient, understand their background, understand, what their laboratory studies are saying, what their vital signs are showing you. And that is how you make a diagnosis and then form a treatment plan. And we talked in that first session that we had about how to collect a thorough medical history and what that means. And so today we'll sort of breeze by that a little bit, but if you're feeling confused or overwhelmed, just know that I go into much more detail on that in my first lecture. We also talked about how to perform a thorough full body skin examination. So as a dermatologist, I haven't used a stethoscope in like 5 or 6 years. So when I am examining a patient, I don't do a full, not necessarily, well, sometimes I do, but rarely. I don't need to do like a heart and lung examination. I don't need to feel for their liver and spleen unless I'm worried about metastatic cancer or something like that. I'm not listening to their lungs. I'm not looking in the back of their eyeballs. My exam is very focused on the skin, and we'll review that a little bit more. And so we talked about how to do a thorough head to toe exam, looking at the scalp, looking inside the mouth, looking at the genitals, how to examine nails, all of that stuff. And then the last thing we talked about last time was morphology, which is how you describe what you see. So is it, if you see a little bump, that's called a papule in our language. If you see like a flat area that's less than 1 centimeter, that's called a macule. And there's this whole other language that goes into dermatology, which can make it intimidating. Even doctors in other specialties get nervous talking to dermatologists about, if say they have a patient who has some skin findings, they get nervous talking to the dermatologist because they might not be familiar or as familiar with that morphology terminology. And they're worried they're going to say something wrong, which I never want a doctor to feel intimidated talking to another doctor. We all have our specialties. I can't talk to a cardiologist about the nuances of the heart rhythms that they're listening to with their stethoscope. But once you become a specialist, you don't forget the medicine that you have already learned in medical school and in your prior training, but you do focus more on your specialty. And so that's what you are good at. Okay. So today, we will briefly review the function of the skin. We will review skin anatomy just a little bit. I know you've had multiple derm talks by other people too, and so you've probably gone into the anatomy of the skin quite a bit. And then we'll do 2 cases of emergency dermatology. And people might say like, emergency dermatology, what does that mean? Like, I think of dermatology as acne and moles. And yeah, a lot of day-to-day dermatology is not an emergency, but there are things that land you in the hospital when you have something going wrong with your skin. And those are the cases we're going to see today. The other thing is when something goes wrong in the skin, it can get a little bit graphic. So the photos today I just want to give like a warning if skin stuff can kind of like, it gives some people the heebie-jeebies a little bit. So I'll give like some warnings before any photos come up, because it's hard to look at. Like, you feel the pain of these people sometimes when you see their skin disease, and some people can handle that and some people need practice handling that. It's also it's good to know where you're at with like looking at medical stuff. You don't want to find out that you're afraid of blood your 4th year of medical school. Like, you got to know what you're comfortable with, and it's okay to not feel comfortable with those things to start, but you have to get comfortable with those things by the end of your medical training in order to be a doctor that's able to interact with their patients and serve your patients well. Now, I do not have the YouTube live stream up on my computer. I don't have two devices here, so I can't see all of your questions, but some of those questions will get kind of forwarded along to me as well as your responses so that we can kind of keep this as interactive as possible. And I really encourage you guys to interact. Don't worry about wrong answers or saying anything that's incorrect, because I feel like that's where growth stops. It's so much better to like make a guess, put your nickel down on something, because that's when you learn. Is if you get it right, that's really exciting. It reinforces that good concept. And if you get it wrong, you remember that and you learn for next time. So don't hesitate to participate. I think that makes shadowing in real life, but also in this context, a lot more enriching. All right. So first of all, let's just briefly, the other thing I was going to say is that I'm going to go through the cases kind of quickly. And then at the end, we'll have time for questions about just like general dermatology or getting into medicine or all of that. I want to do the shadowing of the cases up front so that if you're not interested in talking about like medical school and beyond, you can just tune out at that point. But if you have additional questions, you can sort of stick around for that. But we'll do the shadowing first. So let's just talk about functions of the skin. Can you guys like type out some things like what is the purpose of having skin? Like, why do we have skin? What does it do? How does it serve us as humans? And just like think through that. You can type in some of your answers. I'll give you like 20 seconds. So protection, absolutely. I think that's great. Insulation, absolutely. So temperature regulation, right? If you didn't, you can just imagine like if you've ever had a super bad sunburn and you like get the chills from it, that's because your insulation barrier has been disrupted. Good. First line of defense. Absolutely. So you're not just defending against like the physical elements like UV radiation or cold temperature, but you're also defending against pathogens. So things that exist in the environment that can cause infection like bacteria and viruses and fungi. And sometimes those infections show up on the skin as well. Keeps you waterproof. Sensory, I see coming through. That's great. So sensory is super important. Your ability to touch and feel pain, itch, numbness, tingling, that is so, so important for how you interact with the world around you. When they talk about like the senses, like sight, vision, or not sight is vision, sight and smell and taste, touch is the most important sense. It's what keeps you completely safe. And then structure, right? Like, can you imagine your body if you didn't have skin? You'd have things falling all over the place. Absolutely. So those are all really good answers. And this just sort of like reviews all of those things. So kind of all the stuff we talked about, you know, making sure your temperature is well regulated, making sure you can feel your surroundings. When we talk about it being a barrier to pathogens, that's called your immunologic barrier. It's the thing that kind of rings the alarm bell to the internal system, like, hey, you're coming in contact with something dangerous here. A physical barrier, absolutely. We didn't really touch on this, but injury repair. So if you get cut, how your skin kind of heals itself in order to keep you protected and to keep those other functions intact. And then the other thing we didn't really talk about is appearance. So your skin, your hair, your nails are a reflection of, can be a reflection of your internal health. There is a lot that can get communicated by your skin for better or worse. So if you think about our society right now, the color of your skin can tell something about your ethnic background. It can talk to you about like, what's your sun exposure history been like? Do you have wrinkles or not? That really helps us know how old somebody is. What color is your hair? Is it gray? Is it black? Is it red? Those are all communication things. And that is an equally important part of having skin. So the reason I talk about this is because what lands somebody in the hospital for their skin disease? And it's really when one or more of these functions of the skin is disrupted. So say you're experiencing intense skin pain. So that's sensation. That you're going to go to the hospital for that. You're going to go to the ER if your skin is in such agony that you like can't walk or talk or function in society. If your immunologic barrier gets broken down and you have a terrible infection, that would be another reason to go into the hospital. if you have a skin disease going on where your entire skin turns red and you can't regulate your temperature, you have chills and a fever, and you're not able to get warm, and you're losing tons of fluid because all of your skin is red and you're sweating like crazy, that's going to land you in the hospital. And then of course, if your physical barrier has been disrupted, so you slice through your skin, you're blistering, those are all reasons that you need to seek emergency dermatology care. I think the only one that doesn't land you in the hospital is like appearance. And just to sort of review what the skin looks like, on the right here, we have sort of a cartoon rendering of a slice of skin, this being like the outer layers of the skin up here, and this being the deeper layers, the fatty layer of the skin down here. And what does that look like under a microscope? So on the left here, this is a skin biopsy, meaning that someone took a little skin sample and mounted it on a slide and then put it under a microscope. It's also been stained. So if you look at your skin under a microscope, it's not purple and pink like this. We use different stains called hematoxylin and eosin to actually stain the tissue, and different cells will absorb different pigment. So if you like up here, where's my cursor? Up here, this is called basket weave orthokeratosis. And this is the very top layer of your dead skin cells. This is also called the stratum corneum. And that kind of translates to this area over here. And then you have this like living layer of skin cells here. You have this basal layer, this bottom layer here. That's where all these skin cells are generated from. And they sort of make their way over the course of 30-ish days to the top layer of skin. And then there's other things going on in the skin too. You have your hair follicles, your sweat glands, you have blood vessels. So if anything goes wrong in any of those layers, you end up with skin disease. So if those very, very top layers are shedding, you have one skin disease. If you have problems in your epidermis, this top layer of skin, you can have hundreds of other skin diseases. If there's something wrong with your blood vessels or your sweat glands, they all generate different problems. So understanding that the skin is incredibly complex and made up of different layers, and the skin disease you're seeing is really a reflection of which layer of skin is affected. Makes sense. I do want to comment on one thing that came in about the function of the skin, and it says to release toxins. And I have to make a comment on that because your skin does absolutely nothing to release toxins. When people talk about like sweating out, like say you have a really bad hangover and you're like, I'm going to go on a run so I can just sweat it out. That's not doing anything to get rid of like the alcohol in your system. Okay. Your liver and your kidneys, which are internal organs, are doing all of the filtering of toxins for you. And then you pee them out, or you poop them out, or you throw them up. But your skin doesn't actually do anything to like get rid of toxins. And I think that is a really common thing that people assume. That's incorrect. All right. And then when we talk about these other layers of the skin, so like these top layers, these middle layers, these deeper layers, like I said, that kind of determines what you see. So if we look on the far left here, this is a specific skin disease. And if you guys know what it is, you can kind of type it out. Or if you know what either of these are, you can answer as well. But this skin disease affects the very top layers of the skin. And you can kind of see that all this whitish yellow scale, this is scale. And scale means that that very top layer, the stratum corneum, has been affected. And so that tells you that this skin disease lies in the top layers of the skin. This one here, so these are blisters. So blisters is not really a dermatologic term. We call them vesicles when they're less than 1 centimeter. So these little guys are vesicles. And then we call them bullae, or bulla is the singular form, when they're greater than 1 centimeter. So that's like the derm terms for blistering. And you can imagine what's happening when you have a blister like this is that psoriasis. Yeah, you guys are right. This is psoriasis. It's really intense psoriasis. But yes, this, so people are wondering, is this a burn of some kind? So this is a disease called bullous pemphigoid. And what happens in this disease is the top layers of skin separate from the deeper layers. And so in this photo here, when you have bullous pemphigoid, you get basically all of these cells that are kind of purplish lift off this pink dermis here. And so you get this like space, fluid-filled space in between. And so that's where the issue is when you have bullous pemphigoid, there is a disruption of the junction between the epidermis and the dermis. So that's a deeper process than psoriasis, which was that which is this one here, bullous pemphigoid. And then this is something called paniculitis, and that is inflammation of the fat or the vessels in the fatty layer of the tissue. And what you can really see when someone has something like paniculitis is that the borders of the skin disease become very poorly defined. And you can imagine if you have an issue going down in your fat, which is way, way down here, you can't even see fat in this biopsy. This is just the epidermis and dermis. So if you have an issue going on way in the fat, by the time that issue can kind of be seen on the skin, it's not as well demarcated or as clear. To me, it's like if you put like a tennis ball under your mattress, you're not going to really see the outline. And that's what paniculitis is like, versus if you put a tennis ball under your top layer, like your top sheet, that's like having an issue going on in the epidermis. It's going to be a lot more apparent. The lines of that skin disease are going to be a lot more what we call well demarcated. You'll be able to see the edges of what's going on better. And so being able to look at the skin and understand, where is the issue? Is it in the fat? Is it in the dermis? Is it at the dermal epidermal junction? Or is it in the epidermis? When you're a dermatologist, that is like something that's always, always going through my head. I don't expect you guys to know that. You have not gone through dermatology residency yet, but just know that when I'm looking at someone's skin, I'm always thinking like, what part of the skin is affected and how is it affected? Okay, now that I know it's the epidermis or the dermis or the fat, what are all the things that can show up in the epidermis or dermis or fat? Okay, so let's go on to our first case here. So case one is patient JT. JT is a 7-year-old girl who presents to the emergency room with a rash on the lower extremities that has been progressively worsening over the past 24 hours. JT was in her usual state of health until 2 days ago when she developed a low-grade fever, abdominal pain, and fatigue. Yesterday, she began developing non-tender, non-itchy red spots on the lower legs and buttocks. They have since become more numerous. So this sort of brief, what we call history of present illness, is basically, what does the patient tell you when they show up in the emergency room? Like, what did they say? They said, okay, I was fine until, well, in this case, probably this person's parents told them this, but my kid was fine until 24 hours ago in terms of this rash. But now thinking back on it, a couple days ago, she started feeling kind of crummy, and these are the things she explained. Now, it is not the patient's job to tell you all the details. They don't know what's important and what's not important. And as you progress in your medical knowledge, being able to ask really specific questions helps. So maybe they wouldn't have mentioned that she had abdominal pain because they're thinking, well, I'm coming in because she has this rash. The abdominal pain isn't that big of a deal. So you have to coax out of them, are they having any abdominal pain? You sometimes have to ask it very, very explicitly in order for them to share that information with you. They also might not volunteer like, oh, these spots aren't itchy, these spots aren't tender. So you have to ask, are these spots itchy? Are they tender? Are there other things, if you were looking at this information, what else would you ask this patient? Like, what else do you want to know? And I'll show you, let's see if I can show you and that's the rash she comes in with. So she shows up, you put her in a gown, you got this information from the front desk who took her check-in, and you go in and you see this. What other things what do you want to know about this person? And this is something too that a lot of, when you're a medical student, this is probably the first thing that they'll do. When did it start? Good. This is the first thing that they'll want you to do is go blindly into a patient room and collect as much information as possible. Because by the time, as a medical student, you go in, you talk to the patient, you talk to the parents, you get all the information that you possibly can. And then you go out and you talk to the doctor and you say, they said this, 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 and this. And the better the medical student you are, the more you've progressed in your training, the better you're going to be able to communicate the relevant information that they told you, the more you're going to be able to collect information that they care about. So good. So current medications, allergies, recent travel, these are such good things. So a skin history. So one of the most common questions that you should ask is, has this ever happened to you before? Because like, what if they're like, oh yeah, this happened last year when she took X medication or something. Like that's going to be incredibly helpful for you. Their diet. So diet sometimes plays a role in skin disease, though quite rarely. In someone who has like what I would call a traditional family life, meaning they live in a home, they eat, they don't have any food scarcity, so they're not homeless, they don't have major food allergies. It's really rare for their skin to manifest with certain diseases. But say someone's like an alcoholic and they're not getting good nutrition, or they're very elderly and they only cook toast for themselves and they're not getting adequate nutrition, those are the people who show up with nutritional deficiency issues manifesting on the skin. All right, I'm just going to scroll through some of these comments too. Good. Allergies, exposed to any poisonous plants. That's really good, right? So like, did they go hiking? Could this be terrible poison oak? Any type of like new exposure. So that's all really good stuff. So the next part is to sort of get this like thorough history. And every time you talk to a patient, you should be getting their complete medical history. So you want to know, does this person have any other diagnoses? So this 7-year-old has attention deficit hyperactivity disorder. She might have had strep throat a couple weeks ago, but she wasn't really sure. Like she had a sore throat, but then it kind of got better. So usually past medical history is for like chronic diseases, meaning diseases they've had for a long time. But as part of my past medical history with patients, I often will ask, have you had any illness in the past month or 2 months, depending on what I think might be going on. She's never had surgery. There's no family history of autoimmune, clotting, or bleeding disorders. And sometimes instead of saying, it's like, so is it really relevant here if her grandma had breast cancer? No, I'm not worried that anything related to a cancer history is happening in this like 7-year-old. But asking a pertinent like negative family history can be really helpful too. So when I'm looking at skin that looks like this, as a dermatologist, I have a feeling that this person is having some issue with their blood. And the reason for that is because if you look at how dark these are, and the other part of this is if you were to push on these, like press your finger to it and release, it's not going to blanch. So if I hate to harp on sunburns, but think about if you've ever had a sunburn or any type of like allergic reaction. Usually if you press the skin and you release, you get something called blanching, meaning that the skin turns temporarily white because you've pressed on the blood vessels and closed them off. You've squeezed all of the blood out of that blood vessel temporarily. And then when you release, it fills back up with blood and the color comes back. When something is this dark, you can almost bet that it's going to be what we call non-blanchable, meaning when you push down and you release, that redness stays. And what that typically means is that there are red blood cells that are no longer contained within the blood vessel. Because if they're within the blood vessel and you push on the blood vessel, whoop, you squirt all the blood out and you release, whoop, it fills back up, everything turns red again. If the blood cells have gotten outside of the vessel, it doesn't matter how much you press on it, those blood cells are still sitting there, those red blood cells. And so it's going to be purple or red no matter what you do. So that's why I ask about a history of bleeding disorders, because if they had one, that might clue me in onto what could be going on here. But they said, nope, no bleeding issues. They live with their parents and an older brother. They don't have any pets. They have no recent travel history. So you guys ask great questions. Medications can be really important because medications are infamous for causing skin rashes. So she takes Ritalin for her ADHD, but this is not a new medication and she hasn't had any changes in the dosing. So that can be another thing. If someone's had a medication dose change where their dose increased, even if they've never had a reaction before, sometimes a higher dose can elicit a skin issue. So I always don't just ask about new medications. I want to know all the meds they've been on and if there've been any recent dose changes. And then she takes Tylenol once in a while. And most recently, a couple weeks ago, when she had this thought maybe strep throat. She's allergic to penicillin. And then for kids, I usually want to know if their immunizations are up to date because there are a lot of people in this country who don't vaccinate their children, unfortunately. And so they can be prone to diseases like measles and mumps and rubella, which are really rare to see these days, but now they're kind of coming, like I've seen a couple cases of measles, which is really really shouldn't happen, but it's because kids aren't vaccinated. And so you want to know, because if this person says, oh no, I don't vaccinate my kids, then you have to really start thinking of other infectious diseases as being potentially causative here. All right. And then the other thing you always want to do is get a review of systems. So this is where you just go down the checklist of all the different body systems and figure out, like, is there anything wrong with how you're feeling overall? Is there anything wrong with your eyes, your ears, your nose, your throat, your heart, your lungs? And you have to ask them this because, again, patients don't know what's relevant. You're the doctor or you're the medical student. You're the person who is kind of trying to put together this puzzle. And if you don't have all the pieces, it's really hard to solve the puzzle. So you have to do your due diligence in collecting all of that information. So even if you talk to them and they've offered up some information, I usually just go down this checklist with patients to make sure there's nothing that got left out. So when we did that, this patient, when we got to the MSK, stands for musculoskeletal, they're like, oh yeah, I'm having like pain in my ankles and wrists. You know, a 7-year-old might not offer that up. They don't know what joint pain is. They probably never experienced something like that before. Other things, so fatigue, sore throat. If someone, I'm worried about them bleeding, like I saw that kind of bleeding under the skin look when I looked at them, I will ask about other areas in the body that can bleed. So hemoptysis means coughing up blood. And I would be what I want to know, because if I think the blood vessels in their legs might be affected, let's make sure the blood vessels in their lungs are doing okay. They said yes to abdominal pain. So then I'm going to ask them more questions about what they're experiencing in their gut. So BRBPR stands for bright red blood per rectum. And when someone is bleeding in their GI tract, especially in sort of the more, well, I would say distal. So if they're bleeding closer to where their anus is, that blood is going to come out bright red. Whereas if they are bleeding higher up in their GI tract, like in their stomach or in their small intestines, they'll have something called melena. And melena is black stool. And that's basically because blood has entered the stool, but then made its way through the entire GI tract. So by the time it comes out, it's black. So I always want to ask both of those. Do you have bright red blood or do you have black stools? Do you have nausea or vomiting? Do you have diarrhea? The other thing I'll ask is more bleeding. So hematuria. So this is genitourinary symptoms. Do you have blood in your urine? So someone might not offer up like, hey, my pee's kind of orange or my pee's kind of like rusty colored, because they might just think, oh, I'm dehydrated, but that's a sign of having blood in the urine. So you also want to ask, could they be bleeding in their urethra or in their genitourinary tract? And then neuro, psych, and endocrine, like what else is going on in those areas? Okay, so let's get into the physical examination. These are the legs you see. Pretend you're describing these legs to someone who hasn't seen the patient. How would you describe this? What would you tell them you're seeing? It is so important to practice explaining what you see. So just do that now. There's no like really wrong answers here. This is a really complex presentation on the skin. There's a lot of stuff going on here. So like if I was like to close my eyes, this is how I always think about describing something. Like, could I picture what this kid has going on based on what you're telling me? So I'll just leave this up here for a couple seconds and we'll kind of talk through what you're seeing. Bright red circles down the legs. Good. That is really helpful. So in dermatology, when we want to say circle, we call it annular, which means ring-like. So circles would be before you learn the terminology, and then you get fancy and you call them annular. Good. Bright red lesions. Good. So not just saying red, but like, what is the quality of that redness? So bright red, is it pink? Is it dusky? Is it purple? So if you look at like this red versus this red, like how are they different? They get darker and more numerous as you travel down closer to the feet. Excellent. These are good. Yellow knees. Good. So you can pick up on a little bit of yellowness here. Blotchy. Absolutely. And then they also, this is harder to pick up on because you probably haven't examined as many children as I have. But these ankles are like pretty swollen. You lose the ability, and you can see this kid has skinny legs, and then all of a sudden you can't see their ankle bones. So to me, that's a sign of like some swelling in the feet, which is common in this condition that's going on right now. And we'll get around to that. Those are really good. You guys are awesome. So in a physical exam, you don't just want to like look at the patient, but you also want to get their vital signs. So they had a normal blood pressure, their heart rate was a little high, but nothing crazy. Very low grade fever, they're breathing okay. So the general exam is like, what does the patient look like? Like from the doorway, can you get a sense of if this patient is in pain or if this patient feels like crap? That's sort of like my feelings on things. And the patient's just sort of like there, they're not writhing on the bed. They're not breathing really fast or really hard. They're not screaming or moaning or clutching a part of their body. That like can really tell you a lot about how intense this skin disease is in that patient. And then with the skin exam, this is how I would describe it, which is numerous erythematous. So erythematous means red, non-blanching, which is what we talked about when you press on it and that purple doesn't go away. Papules. So papules means you can feel it. If you were to run your hand over the skin, there's a bump there. It's not completely flat. And thin plaques. So papule, a large papule is a plaque, which appear annular, so ring-like, and range from 1 to 4 centimeters. So also knowing the size of the lesions is helpful. If you say they have red splotches, well, how big is a splotch? Distributed on the thighs, buttocks, shins, and dorsal feet. So dorsal means the top sides of the feet, rather involving the palms or soles. And then you can't see this in the photos, but other parts of the skin exam that are really important to always look at are the mucous membranes. You need to look in the eyes. No conjunctival injection just means their eyes aren't red. The oral mucosa, so look in the mouth, looks clear. Do you check their palms and soles? Because there are certain skin diseases that are classic for showing up on the palms and soles. So, and then last is like genitalia. So she doesn't, her vulvar area is not involved. And then she has a little bit of enlargement of her lymph nodes in her neck. The reason it's important to have, these are what we call pertinent negatives. Pertinent negatives mean that you looked there and you checked and it's not there. And sometimes knowing that something's not showing up is just as helpful. So, you know, when someone tells me the palms and soles are clear, that makes me feel a lot better that it's not like an active infection. A lot of times active infections can appear on the palms and soles. Same with like mucous membranes, like mucous membrane involvement happens in a handful of dermatologic diseases. So when you tell me that the mucous membranes are not involved, I can like kind of cross a few things off of my list. So that's really important. It also communicates to the primary team. So I'm a dermatologist, I'm being consulted. They're asking me for my opinion on what's going on in the skin. They have an emergency room physician that's taking care of them and taking care of all the other stuff, but I'm the dermatologist giving my skin impressions. It tells the primary team, the emergency room team, hey, I looked at their mucous membranes. I looked at their genitalia. I looked at their palms and soles. If you don't include that information, to me, it means you didn't do it. Okay, and then we got some labs. And labs can sometimes be helpful, but I don't rely on labs because a lot of times when you're seeing a patient in the emergency room, they've had their labs drawn, meaning their blood has been taken to get the labs, but you actually don't have the lab results yet. So being able to just diagnose based on what you see can be really helpful. But in this case, they had a complete blood count that was normal. That's really important because there's a type of blood cell called a platelet that helps you clot your blood so that if you cut yourself, you can make a clot there so you don't just bleed out. So if someone has an issue with their platelets, they're going to be more prone to bleeding. So that's why I would check a CBC or a complete blood count in this patient to make sure, one, that they have like platelets, their platelet count is normal, but two, to make sure that their red blood cell count is normal, because if it's low, that means they could be bleeding into some other part of their body that we haven't identified yet. So we'll also get like a metabolic panel to make sure their liver and kidneys and everything look good and don't seem affected. A urine analysis is helpful. So this patient has 1+ proteinuria, meaning they're actually peeing out a little bit of protein into their urine. And that can mean that there's some strain on the kidneys going on in some way. And obviously most patients don't come in going, oh, my kidneys hurt. It's not something they really know about, like where that exists in their body or what that would feel like. So this is picking up like micro strain on the kidneys. And then a fecal occult blood test, that is where you put your finger up somebody's butt and you smear it on a piece of paper and you see if they have blood in their stool. And that's really important to know if they're bleeding in their GI tract. And then blood cultures, so you want to rule out infection. Those weren't available when we saw the patient. And then an ASO titer is actually to look for a recent strep infection to see if they had strep throat. So remember a couple weeks ago, she said, hey, you might have strep. That's what this is for. Also, if you guys have questions about anything as I'm going through this, I realize this is a lot of information, but this is all part of like the information gathering session. So now we'll kind of like talk a little bit about what we saw on there. So when we talked about those like non-blanching red to purple papules and papules and patches, this is what happens. So these little stalks represent arteries and veins in the skin. And they basically, when you bleed out, you get this like purplish color that fills the skin. That's just red blood cells. And it says, if someone goes into urgent care for a skin condition as this, how would a dermatologist see them? So, and why are they not usually on site? So most dermatologists will, so one, there are dermatologists that contract with hospitals. So for example, like I am on staff at a hospital, but I work in private practice. And so what would happen is if someone showed up to the emergency room and the ER doctor thought, I need a dermatologist right now to tell me if there's an issue here, they would call me or one of the other dermatologists that's on staff, and we would come to the hospital and see that patient. There are too many skin diseases to always have a dermatologist available to come in for that. And the reason for that is most derm things are not emergencies. So most people can be told by the ER, hey, this isn't going to kill you. You don't need to be hospitalized for this. Let's get you set up for a dermatology clinic appointment in the next couple of days. There are so few dermatologists in the United States. There are not very many of us. And so to see every patient who comes to the ER with a skin problem would not be feasible. The other thing is you don't want to essentially train your patients to show up in the ER for every skin problem, okay? Because it's much faster to go to the ER than it is to wait 2 weeks for a dermatology appointment. And the fact of the matter is some patients are really impatient and they go to the ER even if what they have going on is not an emergency, but it's an emergency to them. And so it helps doctors sort of filter out what are true emergencies versus what are things that can wait 2 days, 2 weeks, 2 months. I've had people show up to the ER for like skin cancer. Okay, a skin cancer is not going to kill you in 2 days or 2 months. So those are not real emergencies, but I don't expect patients to know what's a dermatology emergency and what's not. And then someone asked, at this point, would a fungal infection be ruled out? So no. So that blood culture that we got, which is to test the blood for bacteria, sometimes viruses, sometimes fungus, would be possible. To me, when I look at that, there's not a chance in heck that that's a fungal infection. So I probably wouldn't even do any fungal cultures. So the other part is being a dermatologist, you learn like, what does fungus look like on the skin? What does a fungal infection within the body look like? And how does that manifest on the skin? And so you might want to, like people who are not as familiar with dermatology might want to order this whole panel of testing, but that gets really expensive and that bill gets passed on to the patient and onto the healthcare system. So involving a specialist who can look at a skin disease and go, okay, I think it's A, B, C, or D, but it's definitely not E, F, G, then that really can help guide testing so that the testing you're doing is meaningful and relevant. So if I saw a patient like this, I would say, you know, I wouldn't really be worried about a fungal infection, so I probably wouldn't get any type of fungal culture. But that's a good question. And so purpura in the skin can look like what I showed you before with those like annular patches, but it can also look like any of these. And you can kind of see that red has like a purple hue to it. And that's because those red blood cells have spilled outside of the blood vessels. This is something called actinic purpura. It happens in older people. Older people have really fragile blood vessels in their forearms. And so when they like bang their arm on something or they're carrying heavy groceries and that bag is like pulling down on their arms, they might spontaneously sort of develop these bruises. And that's just from the blood vessels in their skin being traumatized and leaking out. And so that can happen. And then these are other examples of what purpura can look like. And there are tons and tons of causes of purpura. We're not going to get into that because I think that is like advanced dermatology and we're just doing an introduction here. But just know when you see purple on the skin that when you press and it doesn't blanch, that's purpura. Within purpura, there's macular purpura, meaning those purpura are completely flat when you touch them. And then there's a very special kind of purpura called palpable purpura. And palpable means you can feel it, right? If someone has a palpable pulse, you can feel their pulse. If they have palpable purpura, that means that you don't just see their purpura, but if you were to run your hand over the surface of their skin, you would feel it too. And it's exactly, a bruise is a type of purpura. So we don't call them bruises in dermatology, we call them ecchymosis. That's the same thing. A bruise is an ecchymosis, but that is a type of purpura. So that's perfect. That means you totally grasp it. That's exactly what a bruise is. You like go out one night drinking and you wake up with a bruise because you banged it on something and your blood vessels like spilled out some blood cells, that's a bruise, that's purpura. Most of you have probably had purpura in your life. So when you have something called palpable purpura, that means you have two things going on. You have hemorrhage, meaning bleeding into the surrounding tissue. That's just what purpura are. But then you also have this component of inflammation, and inflammation is what gives you swelling. And so when you have hemorrhage or spilling of blood vessels or blood cells plus inflammation, that's palpable purpura. And palpable purpura really means one thing, and that's leukocytoclastic vasculitis. And that means vasculitis or inflammation of the blood vessels. Are there differences between how you would perform skin exams on patients of color? No. So I examine a patient who has darker skin the same way I would examine a patient with really fair skin. The biggest difference is when you're looking at someone who has skin of color, which we have a case of that coming up, redness is not as apparent. So you have to be really good at picking up very subtle redness. What might look like bright red in someone who's very fair looks like very, very faint pink, or even just a little bit of darkening in someone who has darker skin. So it's being able to pick up on those nuances, but the way I examine someone does not change based on their skin color. You just have to be a little bit more perceptive in darker skin types. And I think there is a comfort level with darker skin that comes after seeing lots and lots of patients who have a wide variety of skin colors. So putting it all together. So you collect all this information and you have to figure out like what's important, what's not important, what is how I'm seeing like translating into what's actually going on. And so when I look at this child who has abdominal pain, joint pain, palpable purpura, and kidney symptoms. So that kidney issue was when we saw that there was protein in their urine. That means their kidney is probably affected. That altogether is what we call a classic sort of, well, it's not really a trio, it's more four things of what we call Henoch-Schönlein purpura. That is a very specific type of purpura that's more common in kids. And we'll talk a little bit about what that means. So Henoch-Schönlein purpura is a diagnosis that is the most common cause of purpura in children. The other name for it is something called IGA vasculitis. So vasculitis means inflammation of the blood vessels. And you can imagine if blood vessels get inflamed enough, they might start to get leaky and start leaking out those red blood cells into the surrounding tissue. And so that's what happens when you have it. You have this it's almost like an immune reaction where these immunoglobulins, which are produced by your immune system, start binding to the blood vessel walls and causing irritation. And then those blood vessel walls get leaky. And when you have someone with Henoch-Schönlein purpura or IgA vasculitis, they sort of tend to present very classically with a few very key things. So about 50% of them will have kidney symptoms. 50% will have abdominal pain. 100% of the time, they have to have this purpuric rash. If they don't have purpura, they don't have IgA vasculitis. That is a requirement for the diagnosis. And then about 75% will have joint pain. And so it's just something to keep in mind. Some people will have this like GI issue, but this is what Henoch-Schönlein purpura looks like. And now you go, okay, well, this kid came to you, they're in the ER, like, what do you do for them now that you've made this diagnosis? And really it's supportive care. And supportive care means you're not giving them any medication, you're just helping them feel better. So that could be giving them IV fluids, like say their stomach had been hurting, so they weren't able to drink water or drink fluids for the past 24 hours. You would kind of give them intravenous fluids. You could give them pain medication to make them feel better. Rarely you have to give them steroids to help with their skin disease, or if they looks like they're having bad kidney disease, that would be what you would do. But when and then the other part is if someone comes into the ER, what you're trying to figure out is the doctor in the ER is, does this person need to be admitted to the hospital? Are they sick enough that they need to be in the hospital monitored constantly? Or are they well enough that you can make this diagnosis and send them home and have them follow up in clinic with a dermatologist in a few days? And so for these patients, oftentimes we'll like keep them in the emergency room for 12 hours, give them fluids, make sure they're feeling better, get another set of labs, and then at that point decide if they actually need to be admitted to the hospital overnight or if they can be sent home. And so that is our first case of HSP. The next case does not take as long. So I know that was like a little bit more involved, but I think purpura can be really complex. But the reason that person came to the hospital was really like, if you saw that degree of red happening on your skin, would that not freak you out? And so I think, and if you're having these like vague other symptoms like stomach pain and stuff like that, that might be a reason to like be like, hey, I need to go to the hospital. And then what determines if a person can have purpura easily or even bruise easily? So some people will bruise easily because of the architecture of their blood vessels. So everyone has blood vessels running through their skin. Some people have more robust blood vessels. Some people have more fragile blood vessels. And that is somewhat determined by the quality of your connective tissue, which is the tissue that makes up the lining of your blood vessels. The other thing is people who are really fair skinned tend to show up with bruises more often just because their skin is more pale, it's more translucent. And so if they bruise, it just shows up more. Of course, if you have someone who has really easy bruising when they're young, that can be a sign of leukemia or like a blood cancer. So that can also be a sign that their platelets don't work well. So if someone has bruising beyond their norm, or they've never been a bad bruiser and they suddenly become like start bruising like crazy with no increase in their activity. It's not like they just took up karate or something and then started having bruises. Unexplained purpura always requires further investigation because it can be a reflection of issues with your blood cells. It can be an issue with your bone marrow where you're not making cells correctly. So purpura are serious if they're happening really frequently, or if they're out of the norm for what your baseline level of bruising is. But a few bruises here and there are totally normal. That's part of being human. Our blood vessels are strong, but they're not that strong. So if you traumatize them, they will leak a little bit. That's a good question. Anything else before I move on to the next case? And if you think of questions, we can always come back to this. This next case is more graphic. So just to let you know, the photos that I show you they're going to be more intense. Okay. So case 2, this is patient LM. This is a 36-year-old. Oh, and then are there natural remedies that assist with the treatment of IGA vasculitis? Generally, no. So your body, I don't know what natural really means. I hate the word natural with dermatology because like, if you're going to be a doctor, you're practicing Western medicine, we give medication. No, so IgA vasculitis often will resolve on its own. And if it doesn't, then you usually have to treat it with medication. There's no real natural remedies. It's a good question. So patient LM is a 36-year-old man with history of epilepsy. So that's a seizure disorder for 10 years, well controlled on valproate. Valproate is a seizure medication. While on vacation 3 weeks ago, he ran out of his medication and started taking his sister's carbamazepine. That is a different seizure medication. He presents with general malaise. So malaise means feeling kind of fatigued and icky. It just is sort of like if you feel like you're getting, it's almost like flu-like, and widespread, incredibly painful blisters on the trunk, extremities, mouth, and genitals. Okay, so here comes the picture. Okay, so this is what he comes to the ER like. So people always like joke like, oh, what's a dermatology emergency? This is a dermatology emergency. I'm getting called in the middle of the night if this person shows up to the ER, okay? You can see like, this is not normal, okay? So let's get some history on him. So past medical history, he has epilepsy and he has hypothyroidism. So thyroid doesn't produce enough thyroid hormone. Past surgical history, none, never had surgery. His sister also has epilepsy, which is why he was able to borrow her medication. Lives with his wife and 2 kids. He works as a janitor. His normal medications are valproate and levothyroxine, which is for thyroid issues. And NKDA just means no known drug allergy. So he's never had an allergic reaction to a medication that he is aware of. When you talk to him further, you do this review of systems again to kind of get a sense of like what else could be going on. So he says his eyes feel kind of tender, but he doesn't have any vision changes. He has something called odynophagia, meaning that it's painful when he's swallowing. He doesn't complain of like chest pain or breathing problems. He doesn't complain of like diarrhea or GI upset. He does complain of dysuria, which means pain with peeing. And then he has a little bit of a headache, but those are kind of the other things going on with him. But basically, he does not feel well. So here's the photo. If your doctor sent you into this room to talk to this patient and said, just come out and describe what's going on with his skin, what would you say? How would you describe this? And how would you how do you think that patient is looking when they're talking to you? Are they in pain? Are they just relaxed on the bed? think you can probably like feel this person's discomfort. If you've ever had like a tiny little sore inside your mouth, could just imagine. Looks like a burn. Good. Totally looks like a burn, right? Like you get heat on the skin, and you start to get this like kind of sloughing going on. Absolutely. Now, I agree that this side looks kind of like a burn where like there's been trauma to the skin, and so it's sloughing off. This would be an unusual pattern for a burn, right? When something's presenting so symmetrically like this, that usually means it's an internal cause manifesting on the skin. Whereas if you have something that's asymmetrical or something that's what we call geometric, meaning it looks like, say you had this big like water, like it looked like water had spilled on him or something, hot water had spilled on him. That has a very specific pattern to it. Textured, peeling skin, good. So peeling skin, absolutely. Lips look swollen, so good. It's good to recognize areas of swelling, extreme peeling, blisters, and burns. Good. So those are all really good things. And you might look at this lips and go like, what the heck is going on his lips? So that's dried blood. So he probably had some blistering here that then cracked and dried and turned into this, what we call hemorrhagic or blood-like crust. So could this be a skin infection? Yes, it could be. Chest area has darker blotches. Good. So we would call these patches or plaques. Excellent. These are all really good. I think if you walked into this person's room and you were new to dermatology, you'd probably be pretty scared. So you get his vitals, his blood pressure is elevated and his heart rate is elevated. When you have elevated blood pressure and elevated heart rate, that usually means the patient is under some type of stress. And oftentimes pain is kind of a driver for both your blood pressure going up and your heart rate going up. He doesn't, really low grade fever here. He's breathing okay. So he appears anxious. He's wincing. It's hard for him to cooperate with your skin exam because when he tries to roll over on the bed, his skin is just in so much pain. And the way I would describe this are numerous erythematous, again, that means red, to hyperpigmented targetoid macules. So targetoid means target-like. And let's see if I can, I know what this looks like closer up, but targetoid usually means there's this peripheral rim of one color, and then there's this internal rim of a lighter color, which is harder to appreciate in this. Macules with central epidermal slough. So slough means that top layer of skin is coming off, which you guys said was peeling, which is exactly right. Coalescing, meaning those little bumps are kind of coming together into a larger patch. So they're out here, and then what we call coalescing on the chest, and face with numerous sloughing areas. He has a positive Nikolsky sign, and this is a Nikolsky sign. It's where you would put pressure on the skin and then push with your finger. And if you can get that skin to kind of peel right off, that's a positive Nikolsky sign. And really what that means is that that upper layer of skin is so dead and damaged that it can no longer hold on to the lower or deeper skin layers. And so it pushes off like that. And there are only a few diseases where you can get a positive Nikolsky sign. So that's part of it. If you were to do that on this patient, it would probably be excruciating. So you would, when you're interacting with that patient, would say, I'm going to do a skin test. It's going to be painful. I am so sorry. I'm going to do it one time and then it will be done. All right, here we go. 1, 2, 3, push. You do it. And you say, okay, thank you so much for letting me do that. I know that was incredibly uncomfortable, but you always have to talk your patient through what you're going to do or what tests you're going to do, because you can imagine this guy shows up to your ER. He's really nervous. His skin is coming off. And so it's so important as a physician that you show an incredible amount of empathy. Imagine how you would feel if that was happening to your own skin. You might not be just worried about the pain, but oh my gosh, is this going to heal? Am I going to have big scars on my face from how this happened? So you really have to go into your patient encounters, really feeling for your patient, feeling their pain, feeling their nerves, their anxiety, because that's going to help you not just get a better history and understand what's going on, but it's really going to help you make the patient feel more comfortable. And then when you look at the mucous membranes, you see there is conjunctival injection. So his eyes are red, meaning the eyes are affected. Lips with hemorrhagic crusts, which we talked about, bloody crusts. Numerous ulcerations on the buccal mucosa. So the buccal mucosa is inside the mouth, inside your cheek area. So you see ulcers, so sloughing of skin inside the mouth as well. Palms and soles, again, are clear. And then you look at his genitalia and you see the urethral meatus has an ulceration. So the urethral meatus is the opening. So for boys, when you go pee, where your pee comes out of, that is your urethral meatus. And there's a big ulcer at the tip. Okay. And he told you, hey, it hurts when I pee. That was part of your review of systems. So you're just collecting more and more information. And, oh, I forgot, I already went into what it is. Any guesses of what this is? Were there any clues in the history? We can go back to the history. That might give you a clue of like what happened here, like what went wrong. Everything was going according to plan. He did this one thing. Where would you perform the Nikolsky test? I would usually perform it at the edge of a blister. So if I was going to do a Nikolsky test on him, I would probably pick skin like out here. You don't really need a Nikolsky test when you see this type of sloughing on the skin. Like obviously this top layer of skin is so damaged that it's not adhering, but sometimes they're not this far along when you see them. They're more like this, and you can't tell, is it, you know, a blistering disease or is there something else going on? So you push in a red area that hasn't yet sloughed. But I think the big thing in this guy's history when you're taking it is the change in medication. Exactly. So he started taking his sister's carbamazepine, and drug reactions like this can take several days, usually a few weeks, to start manifesting. So drug reactions are not like you just take one and then you get the rash. There are different types of drug reactions that occur. This is a very specific type of drug reaction, and some drug reactions can happen immediately, like anaphylaxis, where you start choking and not being able to breathe because of swelling within your respiratory tract. But then there are these delayed drug reactions, and that is something to kind of talk about. And it's so important that you talk about this with your patient, because he might not have offered up the information like, hey, I took my sister's medication. So you have to ask, like, what medications, any changes in medications, any supplements, did you start anything over the counter? Because also people can buy a lot of stuff over the counter or from other countries, and they might think it's harmless because they were able to purchase it without a prescription, but that can do a lot of harm. So that's all part of collecting a good medical history, and a medication history is like over-the-counter medications, supplements, and then like other medications as well. Yes. Oh, and that's another possibility. Good. So did his sister's medication interact with his current thyroid medication? So in this case, no, this was just a straight up reaction to carbamazepine, but that is always we're thinking about, right? Like drug interactions. We think about that a lot in dermatology, is like, is the medication I'm giving you going to interfere with another medication that you're already taking? So this disease or this drug reaction is called Stevens-Johnson syndrome, or toxic epidermal necrolysis. And really, Stevens-Johnson syndrome means that 10% or less of the skin has been affected. And then toxic epidermal necrolysis is when more than 30% of the skin has been affected. And then there's this sort of like what we call SJS-TEN overlap, when somewhere between 10 and 30% of the skin has been kind of affected. And so does this mean the drug doesn't completely filter out of your system within 24 hours? Well, that isn't what it means, but yes, there are some drugs that you take it and they're in your system for 100 days. So not all medication gets filtered out quickly. It can be really, really slow. Sometimes you need to build up enough medication in your system to have a reaction. But the other thing that can happen is when you take a new medication for the first time, if your immune system has never recognized or seen that medication before, it doesn't recognize it. So your immune system doesn't attack it. It doesn't have any problems. But as you continue to take that medication, your immune system starts going, you know what? I don't really like this medication. This is not really vibing with me. I'm going to mount this really intense immune response to this medication. And that can take days or weeks or months, depending on the medication. So there are some medications that are known to manifest 3 months out, some are 2 months out, but there are also certain skin diseases like this one, for example, that take a few weeks to months to actually develop. And that is really determined not by the medication, but by your DNA. And how long would it take this patient to recover? It could be months, okay? Because what we'll talk about next, and these are other examples of it. So you can kind of see these like little blistering here. This would be a great place to do a Nikolsky sign. So you can see that skin's wrinkled, so you get a sense that it's not attached anymore. And then you push on it, and it comes right off. You can see here too, these are like rashes with like a dusky center. When you see this dusky purple grayish color, usually that means that skin is dead. It is no longer attached to the underlying skin. It doesn't have a blood supply anymore. So these are other ways that SJS can look in a lighter skinned person. And as you can see, compared to that darker skinned person where their rash looked almost like hyperpigmented or brown, in a fair skinned person, it looks really red. And so that kind of speaks to the differences in examining skin of color. So how long will it take this patient to recover? It could be months. So people who have this issue, they can go blind. So you need to involve an eye doctor or an ophthalmologist to look at their eyes and protect their eyes. Sometimes you have to sew membranes over their eyes to protect their eyes. Some patients lose the ability to close their eyes because of this. They can get something called genitourinary adhesion. So your urethra, which is like your little pee portal that goes from your bladder to the external world, can get so inflamed that it fuses closed. So you have to get a urologist involved, so someone who deals with like the genitourinary tract, to make sure that this person doesn't have long-term inability to pee. They can have lung damage, they can have nutritional issues. Can you imagine that guy is not able to eat, right? So he's going to need nutritional help. Does the skin ever return to normal? Is it prone to scarring? A lot of these people actually don't get scarring, and the reason for that is it's really just the upper layers of their skin that's involved. And so a lot of people do go back to normal, but there are some people who have it all over their body that require something called skin grafting, where you have to take skin from another part of their body and graft it onto the affected areas. These people can be very scarred. Oftentimes we'll admit these patients to the burn unit because, as a lot of you notice, it looks a lot like burns, and it's very similar to a burn in that you lose that top layer of skin, and then you lose all the abilities of your skin. You can't regulate your temperature. Your pain needs to be really well managed. Your sensation can go down, so you can become numb in certain areas. So this is a really, really intense skin disease. It is a terrible thing to have happen, and you can be in the hospital for weeks to months if this happens to you, based on how affected you are, how much of like your internal body is infected or affected compared to like just your skin. But it all starts on the skin. And then treatment is you need to take them off that medication. So that is the most important, is be like, no more carbamazepine for you. You need to document that in their chart as an allergy. I can't tell you how many patients I know who've had allergic reactions to something, and then it never gets documented in their medical chart. And so they, 3, 4, 5 years go by and they're kind of like, oh, I did have an allergic reaction to something once, but I don't remember what medication it is. So it's so important that you document that in their medical chart. And then they need really good wound care. And then there are specific therapies you can put them on, which I won't go into detail about, that are sort of modulate the immune system to kind of shut down that immune process so that they don't continue to blister and that this disease does not continue to progress. How common is this? This is not common. It probably feels more common to me as a dermatologist because I saw a lot of it when I was a resident. These people really show up to the ER and that's pretty much it. But it can happen. And it's one of the reasons why I am such a proponent of not giving medication when it is not necessary, because this was a seizure medication, but antibiotics can cause this. Over-the-counter pain medications like ibuprofen and Advil can cause this. There are over 100 drugs that have been shown to cause Stevens-Johnson syndrome or TEN. And so when someone just gets antibiotics for no good reason in the ER, when they had a viral infection, which doesn't deserve antibiotics, doesn't require antibiotics, and they get that, it's frustrating to physicians. I think it's just frustrating in general because you're potentially exposing somebody to this type of reaction. And I've had patients who had this when I was a resident who had a urinary tract infection and took something. I've had people who had an upper respiratory tract infection and were given antibiotics and had this reaction. So I never want people to live in fear of medication. As a Western, trained doctor, we use medication very carefully to help people, but all medication comes with risks of side effects. This is a terrible, life-altering. A lot of these patients end up with like post-traumatic stress disorder too, so psychiatric problems, just from like you can imagine how traumatic this would be. So it's just a lesson not to give medications just willy-nilly. I think that's it. So that's 2 cases. It went longer than I thought it would go. So thank you for sticking with me if you did. We can end this now, or depending on the moderators and how they feel, if there's any like questions in general. Last time I did this, there weren't a lot of questions, and then I got like 100 DMs that all asked me the same stuff. So if you have a question about like medical school or anything about dermatology, it's better to ask it here so I can answer to everybody, but you can always reach out to me via DM too. I don't always get around to answering every single one, but I definitely do my best. Okay, I think that's it.
Thank you so much, Dr. Ellis, for presenting another wonderful presentation and for showing us some really interesting cases.
Good, I'm glad. Thank you.
It was an honor to have you back again. Thank you.
Of course.
And everyone, make sure you check out her socials. Her Instagram is Dr. Samantha Ellis.
Oh, thanks, guys.
Additionally, thank you all so much for attending. The Google form link has now been posted, and it will also be in the description of this video, so please fill it out within the next 30 minutes. Again, thank you so much, Dr. Ellis. It was such an honor to have you again.